Hello and welcome to the CVL podcast, coming to you from the UT Dallas Center for Vital Longevity, which is dedicated to pursuing research that leads to cognitive health for life. Our goal is to educate you on the latest matters relating to cognition in the brain, and with each episode we'll be interviewing leading scientists and sharing their insights and suggestions to promote cognitive health throughout the lifespan. My name is Amber Kidwai.
And my name is Sarah Munir.
And this is the CVL podcast.
In this episode, we're sitting down with Dr. Frank Lin, a professor of otolaryngology at Johns Hopkins University. His research focuses on hearing loss and its relationship to cognitive health. This is such a fascinating topic because I don't think many people would intuitively think about hearing loss being related to brain health, but as you learn in this episode, it actually makes a lot of sense. We begin with discussing some pretty big policy changes that have come directly from initiatives led by Dr. Lin, including the Over-the-Counter Hearing Act. I didn't realize this before talking with Dr. Lin, but hearing aids used to only be available by prescription, and the entire market was dominated by one player. But thanks to these recent policies, you can now buy hearing aids over the counter. These recent policy changes also opened up the market, so now we're seeing companies that produce your favorite headphones and earbuds entering into the hearing aid market, promising more affordable and innovative solutions. We also discuss how to protect your hearing and how to properly assess your hearing. Dr. Lin tells us about an app his team is developing, which will provide you with your hearing number so that you can monitor your hearing and determine if you need to see a doctor. Our discussion also covers Dr. Lin's research on the relationship between hearing loss and dementia. This connection really emphasizes the implications of hearing health on overall cognitive function. This is a really fascinating episode. However, one thing we need to mention is that we did have some technical issues with our equipment during this recording. This particular episode does not have as good audio quality as our other episodes, which is kind of ironic since it is about hearing. But please bear with us and listen till the end. You'll learn some fascinating stuff about the relationship between hearing loss and dementia. It's definitely worth a listen. So tune in with your listening device, maybe even turn it up a notch, but not too loud. We'll learn why, and let's dive into the world of hearing health with Dr. Frank Lin. So before we get into the science, could you tell us a little bit about your background and how you got interested in this area?
Clinically, I got interested in this area because, it really came clinically. So I'm clinically trained as an ENT surgeon, and then one thing that really, bugged me, but I really noticed when I was going through my residency training is, I would see a kid in clinic, let's say a 7-year-old girl, and let's say we did a hearing test and it shows, let's say, quote-unquote, mild to moderate hearing loss. Just, it could clearly impact how well the child could interact in the playground, the school, and because of that, it would be seen as this, urgent medical matter. It had to be addressed. We had to really optimize how well the kid could hear in the playground, the classroom. But all of a sudden, if the next patient I saw, let's say she's now a 70-year-old woman, with the same hearing test, right? Mm-hmm. Same functional impact of communication, all of a sudden, it was met with a shrug, right? So, it was a bit of a paradox. How could the same functional hearing be critical for a 7-year-old and not critical for a 70-year-old? So that bugged me. And then the reason why it bugged me, I would say, is it flew in the face of what I was personally observing among patients who had some hearing changes as they got older. I saw my family members. I was like, how could that not be important? And you realize if you dig into it more, it was just a notion. It was a notion because hearing changes are so common as we all get older. It's because everybody's hearing, doesn't matter what you do, it monotonically gets worse over your life. Look at the prevalence of hearing loss. It's 1% in kids, right? Mm-hmm. But it's 60, 70% older adults. So I think this notion, if everyone has it, how could it be important? But you realize that was rooted in that just general notion as opposed to any evidence. And there really wasn't evidence of whether hearing is important. So that's what spurred a lot of the research early on was it flew in the face of what I observed clinically. There hadn't been research show one way or another whether it was important or not. Mm-hmm. So it really began a series of steps. Now began the research I did and led the policy and now to a clinical trial and other things I do.
So, this is a really fascinating subject area because, hearing loss is known to affect just over 15% of American adults. And like you said, it's with increased hearing loss with age. And your work has directly led to the recognition of hearing loss as a modifiable risk factor for dementia, which is just kind of quite mind-blowing. I mean, what is the connection between hearing and dementia?
Yeah. So when it began, Amber's, it's funny, like there was actually a paper in 1989. It was published in JAMA, right? So one of the most premier medical journals. And it was this quintessential, it was called a case control study, which is a sort of the basis level of epidemiologic studies. And it showed among 100 cases of dementia, 100 controls, that lo and behold, that hearing levels, or how, your hearing loss severity level, was clearly in a dose-dependent way associated with your odds of having dementia. And that was in 1989. But between 1989 to when I took this topic on in 2010, no one had further pursued it. And I think it was for a couple of reasons. One is because there was just an assumption that, it's because they can't hear, they're doing more poorly on cognitive tests, and that's why they have dementia, right? It's not real dementia. But if you think about it more, it doesn't really make sense, because if some people have hearing change, you're saying that systematically, among all older adults, of which 2/3 have hearing loss, that were systematically biased with cognitive tests, doesn't really make sense. So, but no one really thought about that much. At the same time, the researchers could think about it. People really start hearing, like ENTs, audiologists, don't think about cognition, dementia. Dementia and cognitive experts understand nothing about hearing. So for 20 years, that research just sort of sat there. No one ever did anything with it. So that's a thread we picked up on 20 years later, and we found across these various studies that have been now sort of proven or replicated across multiple different cohorts around the world. This very strong link between the level of your hearing and the odds or risk of progressing with cognitive decline, dementia, brain aging over time. Now, importantly, though, we don't think it's correlational. That would be maybe academically interesting, but doesn't really matter then. But they're causal pathways. So there are three major ones hypothesized for causal pathways. The first one's this notion of cognitive load, and it's the idea when all of our hearing changes, we get older. What it basically means, the inner ear is deteriorating, the inner ear is post-mitotic, it can't regenerate. So it means the inner ear is sending a much more impoverished auditory signal to the brain. So one mechanism linking hearing, let's say cognitive decline, dementia, brain aging, is the notion of cognitive load. Is the brain then constantly having to reallocate brain resources to dealing with that garbled auditory signal, to decode it into meaning, and does that come at the expense of other cognitive subsystems, right? So in that sense, it's not so much that hearing loss causes dementia, but hearing loss can lead to earlier unmasking of dementia phenotypes, because you don't have that cognitive reserve, per se, to buffer against, let's say, AD pathologies and microvascular disease, right?
Yeah, so could we kind of go into, you mentioned cognitive reserve.
Yeah.
So can you kind of break that down a little bit more for our audience who might not have heard that term?
So there's this general notion, right? So, and you guys know this well, if we look at a group of people and we do all these rigorous MRI scans, other imaging of the brain, other biomarkers, you can see the same level of, let's say, various types of pathology, brain structural loss, Alzheimer's, amyloid pathology, neurofibrillary tangles, and tau tangles. You can see the same level in different people, yet one person, frankly, has a dementia phenotype, as in they can no longer do their daily activities, their cognitive scores are very poor. Another person's doing fine, right? So there's not a one-to-one, as we know, correlation between pathology and phenotype. And, one mechanism to hypothesize why that may be the case is the notion of cognitive reserve. Some people have, quote unquote, more efficient, maybe cognitive neural brain networks that can allow someone to better tolerate a level of pathology before it becomes symptomatic. And this we see as across many areas of human medicine, this idea of resilience. But in this case, it's probably some type of resilience of the neural brain networks or
so
cognitive
basically,
networks.
Although their brains look similar through imaging, their behavior is very different.
Exactly.
And there's some difference there, which you're saying is what the cognitive reserve is.
Yeah, exactly. And then the thing with hearing, then this is, I tell you, this is a new idea of cognitive reserve or cognitive load or cognitive resources. Danny Kahneman, for you guys who know him, he unfortunately passed away recently, but Nobel-winning psychologist / economist from Princeton for many years, formed this idea 40 years ago, or 50 years ago. I think this idea of cognitive reserve capacity, right? So with hearing, or let's say hearing loss per se, does the brain constantly have to utilize some of those available cortical brain resources to constantly decoding and dealing with that much more garbled auditory signal when those resources otherwise could have been used to help buffer against other things that can lead to dementia too as well, right? So that's one mechanism. The second mechanism is interesting. It sounds similar, but it's completely different. And it's the idea that hearing loss actually directly now can affect the brain's structural integrity and hence the brain function, right? So, and we see this actually in human studies as well as animal experimental studies, where you see on average that if you give an animal hearing loss and another animal non loss, or you look at humans, some people have greater levels of hearing versus other people, and you follow them over time, you see little faster rates of brain atrophy, particularly of the lateral temporal lobe, other brain regions, which likely has cascading effects. And it makes sense. You have a very impoverished auditory signal sending. And we arguably say, hearing and vision are two dominant sensory afferents, right? I mean, we sort of take it for granted the brain is encased in our skull, and it's really not for essentially 5 or 6 essentially fundamental sensory afferents of the brain. That's the input the brain's getting. So if you lower one of those dials, per se, of the hearing, it makes sense in a way. How could it not affect the brain's, in a way, structure and hence function? And we're seeing that. So in that case, it's interesting. It's actually suggests that hearing loss in of itself directly affects brain structural integrity, which then affects the brain function. So that's a second mechanism.
And sorry, just to kind of clarify, so that lateral temporal lobe that you mentioned, that's also the region where we see the memories happening as well, right?
Yeah.
So this is potentially why it also is the region that we see for auditory signals, and at the same time, it's important for memory. So if it's basically degenerating because an individual, and it's contributing to hearing loss, it can also be contributing to this memory loss.
Yeah, that's right. And Sarah's exactly right. So, in terms of structural effects, we really mainly see in the lateral temporal lobe. So superior, middle, inferior temporal gyri, which are very responsible for processing a lot of the initial auditory information. So you're seeing structural effects there, which those regions of the brain, while they're important for hearing, they also subserve, as you mentioned, a lot of other areas of brain function too, because it's not like this region is this only. There's a lot of crosstalk, to say the least. That's only structural, though. Also functional, though, right? So structural, obviously, is a distal effect of any perturbations to the brain. But if you look at more functional activation, you see that, quote-unquote, hearing loss, hearing changes, affects many different brain regional network activation. And again, it makes sense. If hearing is, let's say, maybe even our dominant sensory afferent the brain relies on for processing the world around us, you impoverish that signal, how does it not affect and perturb different nodes of that network and the edges, and hence the brain's performance?
So what you're saying is a kind of a garbled signal is going into the brain from the ear, and that's causing almost like a rewiring, because that's not kind of efficiently being using that areas of the brain, and so it's being applied to other.
Spot on. Yeah, and you see, like, in terms of, like, say a brain network where, let's say, we consider one node per se, what input is like this information coming from the cochlea, but you're perturbing that node. You're basically like messing with that node. I mean, how does that not affect then all the other nodes that's connected to, as well as reciprocal downstream effects?
Yeah, very fascinating.
So then that pathway is actually different, because it's not indirect. It's actually directly affecting that. A final pathway I mentioned, which is one that's hugely important to mention, which is probably most intuitive, is that honestly you can't hear that well. You can't engage as well. So the effects on, quote unquote, social isolation, loneliness, remaining engaged in cognitively stimulating activities, those are even really sound so obvious in a way, right? You can't hear, you may not be able to go as much, you're not engaged as much. How does that trickle down ultimately to brain function structure too? It's, let's say there's a long base of literature for looking at people who are isolated and otherwise not engaged, how that can affect the brain. So that's a third mechanism. And as you know, these three mechanisms, whether it's cognitive reserve, direct effects on brain function structure, and or let's say social isolation, things like that, they're not mutually exclusive. It's likely a combination of all three when it comes down to it.
Yeah, I mean, I'm sure social isolation basically leads to a lack of stimulation for your brain. So it's just similar to the impoverished stimulation that you were just describing that's coming in through the ear. So it does kind of all link together.
It does, yeah.
So I was reading about your background, one of the studies is the ACHIEVE study. So could you explain to us what the acronym stands for, and then what exactly you were looking at and what you found?
So the ACHIEVE study is a cute acronym, which took many hours of thinking of, right? Because every clinical trial has some cute acronym, right? The cute acronym is the Aging and Cognitive Health Evaluation in Elders study, or the ACHIEVE trial. And what the study was is that all the data we've been talking to date so far, linking hearing and cognition, let's say cognitive decline dementia, is based on observational epidemiologic data. Take large populations of adults in the community, follow them for many years, and lo and behold, and across studies across the world, across the United States, different investigators, we see greater hearing associated with a greater risk of cognitive decline or dementia, which academically fascinating how the brain works, cognitive science. But then if I put on my hat as, let's say, a clinician, as a surgeon, it's like, okay, academic interesting, but who cares? Meaning, who cares is what's my patient, is going to help my patient or not, right? And the obvious question is, does that mean if we quote unquote treat hearing loss, intervene on it with, let's say, hearing aids, other related hearing technologies, does that actually reduce risk, right? Until then, it's always academically interesting. And you realize that question really remained unanswered for many years because you can't answer without a randomized controlled trial. Because you look at all these other studies to date, observational data, and you look at who uses hearing aids, who doesn't. You do see on average people who use hearing aids, they do quote unquote better. They have lower likelihood of, let's say, cognitive dementia, people who don't use hearing aids. But you can apply causation to that, right? Because you can imagine people who use hearing aids versus people who don't are likely to be honestly healthier, wealthier, and better educated, right? So was it the quote unquote the hearing intervention that led them at better results, or the factors that led them to get a hearing aid? So you can't answer that with a clinical trial. So the ACHIEVE trial was that exact clinical trial funded by our tax dollars, NIH, National Institute on Aging, for many years, which we took about 1,000 people across the United States, 70, 84 years old, mild to moderate levels of hearing loss, the bread and butter hearing loss at almost half that age range. Half got hearing intervention, half got a education control intervention, and lo and behold, after 3 years of following them, you see after 3 years, for the population of older adults at increased risk for cognitive decline, that hearing intervention reduces the rate of cognitive loss by nearly 50% over 3 years. Wow. So, and that was just resulted out last year after almost a decade of work. So that was the 2 or 3 minute summary of a lot of people's work over a decade. But until then, or until the trial results came out, we actually never knew if hearing intervention could actually make a difference. Because you can easily say it's too little, too late. It's not restoring hearing. It's a rehabilitative intervention. Maybe it's too little, too late. A lot of other interventions that we've explored for ADRD, Alzheimer's disease-related dementias, things like that, they haven't worked, mainly because in some ways they've been too little, too late, probably, right? In this case, it looks like it's actually not too little, too late, all for intervention which comes at no medical risk, which makes it really, really exciting.
Yeah. So now we're seeing hearing aids not just as an intervention for hearing loss, but also potentially for dementia. So where do you think this is going to go in the next few years?
So I think that the important thing there is that, it's like any trial, we certainly can't infer that treating hearing with hearing aids is going to prevent dementia. Certainly not. Hopefully maybe reduce risk over time. But even then, for this trial, we can't figure that out yet, too, because we need much more long-term follow-up data. But what we can say, I think, from this trial is clearly if we look at some of the other proximal measures that are gapped, health-related quality of life, communication, social function, loneliness, we see improvements on that already. So there's no doubt hearing intervention, we know, has clear, tangible, proximal benefits on your day-to-day life. And then what I like to say to patients that, and now we actually have good evidence suggesting that over time, it could likely help support, improve, and maybe support and promote cognitive health. So from my point of view, when I talk to patients, it's not so much, using this is going to prevent dementia. I never say that at all. It's more like this can clearly now improve social function, communication, safety, and it may be able to support cognitive health over time, right? All for intervention that comes into medical risk. So a lot of what I think as a surgeon, though, in this regard, and I say more as a public health specialist, is that's great, hearing interventions work and things like that, but if hearing aids are still like $4,000 out of pocket, it's like, what gives? And no one wants to use a hearing aid. No one even knows what their hearing level is. So what I focus a lot of my time now is a lot more policy as well as broader awareness initiatives. How do you translate research now into action at the actual ground person root level?
Yeah, it's funny you say that, because I think I was having a conversation with somebody a while ago about how with eyesight people treat it immediately and it's something that people know what their number is and they take care of it. And with hearing, people, there's still some kind of stigma attached to it, even though it's just another sense which is deteriorating in the same way that eyesight is, but there's kind of a stigma and people don't want to treat it or they want to ignore it. But they wouldn't do that with their eyes. So it's just.
So I think you're Amber, you're so spot on there, and I think there are two approaches to that. And one is that you're absolutely right. At the most root cause level, I would say everyone. You roughly know, your blood pressure. You might know your weight. If you're diabetic, your glucose. But I mean, I'm guessing even for you guys, I mean, the last time you ever got your hearing checked or measured was probably when you were in primary school. And no one knows their hearing. So for all us talk about how hearing is so important, if actually no one knows even what their hearing is, then it doesn't really matter. So one of the big initiatives that we're launching this year from the Johns Hopkins Bloomberg School of Public Health is actually a national campaign with various large partners around the country and around the world to put together something called the Hearing Number Initiative, which is basically an initiative to basically empower the average person, beginning as a teenager all the way through my now almost 80-year-old mother, to use a smartphone and just to measure in about 3 to 4 minutes, measure your hearing and to learn your hearing number. And all your hearing number is, it comes from an audiogram, a formal hearing test, which you can do on your phone nowadays. And it basically is the number just tells you how loud do sounds have to be for you to hear. And it's the whole base of all literature on hearing dementia is based on that number. For example, my number, so the lower your number is, closer to 0, the better your hearing, because you hear very soft sounds, right? So my number, I'll tell you, is a 10 in both ears. I think 10 and 12, right ear, left ear, which completely puts me in the range of quote unquote normal hearing, if you want, whatever that means. But if I compare to my daughter, who's now 18, but 16 at the time I had her do her hearing number, hers is a -3, right? How here is like she's a 6-year-old. So when I saw her number, I was sort of taken aback, because if you had asked me, I'm 47, my hearing's 10, it's normal, it's like, oh, my hearing's great, hasn't changed. I'm like, no, right? When I saw my daughter's, I'm like, oh God, I guess I am 30 years older than her. My hearing actually is worse than hers, right? And if I think about it enough, if I'm in a busy restaurant with her, I don't hear quite as well as she does, right? It's because my hearing has changed. But I would never have known that unless you know your hearing number. So that entire initiative is launching end of this year, probably around Thanksgiving. We're launching at Hopkins. It'll be your own, it's a number app on Android, iOS. You go to download for free, learn your hearing number, and just something you track over your lifetime, maybe once a year, much like you track your weight or your blood pressure, and it can clue you in. So my daughter, her hearing number is about, she does not use any device or whatever, but it's about hearing protection. She goes to, she's a Swiftie, when she goes to a Taylor Swift concert or whatever, or a club, just, if it's loud, and it's, like meaning loud enough, and the general rule of thumb I use, if it's loud enough, they need to raise your voice to be heard at arm's length. It's a situation where they're long enough, consider using this type of earplug or something like that, right? So for her, it's that. At my level, it's like, I notice in busy restaurants, I don't hear quite as well. For me, it's going to be likely, maybe eventually, using some type of OTC hearing aid. And there's various ones, like ones that in the future will be integrated within your existing wireless earbuds, right? So is that a AirPod I'm wearing, or is it a hearing aid? Same thing. Or there's actually a really interesting company coming out soon, EssilorLuxottica. You probably never heard of them.
Oh, yeah.
Oh, have you?
They're usually eyeglass.
Oh, yeah.
They work with
So
eyeglasses.
EssilorLuxottica owns 40% of the vision market. They own Ray-Ban, Oakley. They are coming out at the end of this year. And these are wild guys. I've tried them on twice already. They look like just like cool, stylish like glasses, like Ray-Ban glasses. But embedded in the front, always little microphones. In the temple piece is a little speaker you can't see, nothing in your ear. But whoever you look at in a restaurant is who you hear.
Oh, wow.
So those type of...
It's funny. My husband's actually an engineer there, so I'll be seeing if I can get a discount.
Essilor?
Yes.
You're kidding me.
Yes, yeah.
Oh, it's wild.
So he didn't mention anything about that, but
No,
I'll be bringing that up with him.
It's public
let's get
knowledge
those
now.
glasses.
But I think that's the whole thing with them. So the hearing number campaign is obviously going ahead now, and that's all predicated in the past several years. You guys alluded to this very kindly in your intro to me, is that years ago in the U.S. we got a law passed called the Over-the-Counter Hearing Act, which is essentially re-regulating the entire hearing industry that allows companies like Essilor-Luxottica, Samsung, Google, Apple, whatever, these companies to finally enter into, quote-unquote, the hearing aid space. Until then, until this law got passed, though, you could only, if you sold a hearing in the United States, or you could only sell it through a licensed provider like me. You couldn't just sell over the counter. This is what this law that got passed several years ago, went into effect about a year and a half ago. This is what allows companies like Essilor, Bose, HP, Jabra, now it comes with all I know I've heard of, to actually enter into the market and create this really innovative hearing technology. So yes, we call it hearing aid. The hearing aid seems like it's a bad term. Yes, those Essilor glasses have come out. Yes, I think they call it OTC hearing aids. But if you ask me, there's like cool glasses that allow you to hear better. So
it's almost like how your Apple tell you, give you health information as well. It's kind of that merging between technology and health. Yeah.
So, Amber, that's spot on. It's like what this law, and this reason why I pushed so hard for it to get passed eventually, and even years before that to get it moved ahead, is that this allows this grand convergence between, is that a consumer electronic or is it a medical device, right? It's, many cases can be one and the same, right? I mean, for extremes, obviously, it's like a implantable medical device. It's clearly a medical device. But there's a lot of gray area now, and this could never happen before because of regulations. That's why it's crazy. One reason why hearings are so expensive is because the previous regulations is it was a gatekeeper model, sort of a classically, from economics perspective, a low volume, high margin model of business. there are only 5 manufacturers around the world that account for fully 95% of the world's hearing marketplace. That allowed that to stay put. Now with essentially re-regulation, this would allow the field to blow open in terms of innovation and accessibility, costs, and everything like that.
Yeah, and especially as most people know, we have an aging population, and like you said, with age, hearing loss is something that is going to happen. It's probably crucial that we start doing something to address it that's accessible for everyone.
And kind of going back, like you kind of brought up your daughter and her hearing, so that kind of gets me thinking, like, these days, like, I'm guilty of this too, young adults. We walk around with earbuds, headphones. Oh, yeah. Our phones give us warning, right? It'll tell us. Yeah. Most often we ignore it. Yeah. But where do you see the future going with our generation, my generation, and younger adults with their hearing loss? And, I mean, even dementia risk. Yeah. Like, if they're so tied together, what is going to happen with this younger generation?
So I think that brings a broader question. People say, oh, everyone's using earbuds nowadays. Everyone's hearing is going to be terrible. Is it true? I'm not sure. And the reason why I say that is, so I'm old enough, I was born in 76. I'm old enough to remember the first Sony Walkman from the early 80s, where people were saying the exact same thing, right? Don't forget, back then with the Sony Walkmans of those days, those were all analog devices you can turn as loud as you want, right? Nowadays, all devices are digital. So there's actually some volume limiter to some degree where they can limit, especially, like products from Samsung, Apple. A lot of times they have built-in volume limiters. It tells you things like that. So I'm actually not sure that's really borne out in terms of, let's say, personal headphone use and whether or not rates of quote-unquote hearing loss are going up. I mean, if you look at the current prevalence data nowadays versus before, you're not seeing huge jumps.
Yeah,
right?
When you mentioned the 80s, that makes me think of, like, people walking around with boom boxes.
Yeah, right? So this is 50 for 40 years. I think hearing changes for everybody as we age, and that's because the inner ear is post-mitotic, doesn't matter what you do, and it's driven by a lot of genetic, familial, other factors, of which many things we can't control. Noise is one we can prevent to some degree or reduce. But I think headphone use is just, I don't want to say it's a drop in the bucket. I mean, there are probably some extremes. If you really are blasting it 24 hours a day, it's one thing. But I think relatively personal headphone use is relatively a drop in the bucket versus broader concerns around occupational environmental noise exposure. And again, that has gotten better. One of the biggest drivers in the past was occupational noise exposure, railroad industry and factories. That's all regulated now. So those actually, if you look at rates of noise exposure in the workplace nowadays versus 50 years ago, it's a whole lot better, right? So I think it's actually I'm much more of a cup really half full here in this area as opposed to cup half empty on this one, right? Okay. In terms of hearing and, let's say, overall rates of future dementia, hearing, don't forget, it's just one of many risk factors. So I'm not really worried about that in that context, right? If anything, I'd be more worried about environmental air pollution, cardiovascular disease at the macro level. But even though, let's say even cardiovascular disease, I mean, that's actually been going down too relatively, right? So I think there's actually a lot of positive aspects to note there. The one overriding thing, though, as we all know with just rates of dementia, is that we can arguably say the absolute risk of dementia is going down for any given age-adjusted person, but the numbers are going up because everyone's living longer, right? And that's going to accumulate over time. So it's clearly not one risk factor needs to be targeted. There's likely a constellation of things if we're really going to drive down, hopefully, the prevalence down the road.
So what would you say is the most important thing we can do to maintain healthy hearing?
Yeah, so I mean, if you look at, there are all these quote-unquote, there are all these risk factors associated with hearing change over time. And a lot of them are non-modifiable. Age, which is the marker for a lot of stuff, genetic makeup and things like that, right? Even actually, interestingly, skin color is a marker of hearing loss. So there's a correlation between the melanin in your skin and the melanin in your inner ear. The more melanin you have, the more protect your inner ears against likely free radical damage, something like that. So something you can't obviously modify, right? Yeah. So the main modifiable ones are likely cardiovascular disease. So the same small blood vessels that go to your brain also feed your inner ear. But again, you're going to address cardiovascular disease not because you're trying to protect your hearing. Well, maybe you hopefully are, but because for all things. So that's not what I really worry about because we're going to do that anyway. Only unique, I would say the really unique modifiable risk factor for hearing is just noise, right? So the general rule of thumb I use always there, quite simply, is just that if you're in an environment and you're at arm's length with someone and you need to raise your voice to be heard, it's a situation if you're there long enough, you may want to consider using hearing protection. Obviously, you're walking through, let's say, the subway, it's loud. No biggie, right? If you're working the subway 8 hours a day, you probably should use hearing protection. If you're walking through the bar area of a club and it's quite loud for while you're walking through, I wouldn't worry about it. If you're going to be in that club listening to that band for a couple hours, I mean, just get a simple pair of earbuds. And there's some really cool ones nowadays.
Yeah, I was just going to bring that up. There are some really, like, if you're going to go to a band or something, you can get it from Amazon. They're really fashionable, too. They're really right now. You just put it in, looks like a little earring. So there are so many options.
There's so many options there. And just like, it's like you take, it's funny, I'm so old enough to remember when I used to go to clubs in college. I don't really go anymore, but when I used to, right, like 20 years ago in college, it's like, it would be smoky, it'd be gross, right? Mm-hmm. And that, fortunately, I think in many ways, you go to clubs, they're not always so smoky anymore because you can't, right? So that's something we've accepted as a society, that smoking in an enclosed setting is not so great, right? So I think it's hopefully a matter of time as we become more aware of just, hearing, and just that either, yes, you just routinely, throw on a pair of earplugs, or maybe even the concert halls, clubs, you adjust the volume slightly. And it's always a trade-off because there's a certain, there's a certain vibe when the hearing is, when the music is loud, right? Mm-hmm. But there's a sweet spot there where I think it's not so loud like you go home and your ears are ringing for the rest of the night versus still creating the same vibe. And I think you gotta hit a sweet spot. Mm-hmm. And if sometimes you always can't hit it, then just throw on a pair of whatever like cool earplugs where they have out nowadays and just use them, right? Mm-hmm. Yeah.
So, at what point do you think somebody should seek help for hearing loss? Like, are there any guidelines for when it reaches a point when you need to see a specialist?
So I think without a doubt, to some degree, right? And the whole thing with the hearing number campaign, which is just inviting everybody just monitor your own hearing. Just hopefully, in many cases, do it yourself. Yeah. Just monitor yourself and be aware of it. And then if you start noticing some hearing changes, like I guess theoretically I am, get a pair of Essilor glasses and use them every now and then, right? So I think in the vast majority of cases, I would love to see just hearing is just something you just take care of yourself. But without doubt, some people need, quote unquote, more help. You need assistance of even maybe an audiologist or maybe like me as an ENT surgeon. But those are situations where, like, from the medical point of view as an ENT surgeon, clearly if something is hurting your ear, draining your ear, you're noticing sudden change. It's sort of like common sense, I hope, that you see a doctor for that. Absolutely, right? But then for an audiologist, too, I would say, if you feel like you can't figure out what to do next, you really don't understand your hearing, what to do, right? Then clearly you need the services of an audiologist. Or your hearing is getting to a point where you try some OTC devices and you're still struggling, right? Then by all means, go see an audiologist, right? And then they can guide you more, right? Mm-hmm. And this goes with a lot of different sort of situations we manage medically now ourselves, right? Like, I don't know, you have a headache, just take Tylenol every now and then. If it's really not getting better, go see a specialist, right? Same thing, like I'm a runner, so every now and then I get some issues with various body parts when I'm running, and most I get better by itself, and I know how to manage it. After a month it's not getting better, I know I was one physical therapist I see for my running related injuries, and I see her, right? So it's not either or. It's just if we get to the point where there's broad awareness of hearing, that hopefully most people can take care of themselves. But if it's not getting better by yourself, then yes, absolutely go see a specialist.
So I didn't realize you could actually just get hearing aids over the counter.
So this is the new thing, right? So this is as of that over-the-counter Hearing Act.
So you would just go there and say, I mean, how would you know what to get?
Exactly. So it's so funny. How I spend a lot of my time nowadays is actually not, I should say not doing research anymore. I still do a lot of research, but is increasingly leading these more broader national initiatives around hearing. And one of the big ones is, as of a year and a half ago now, the hearing is over the counter. And you can go to Best Buy, and you can go to Walmart. You can buy hearing aid over the counter now, but people don't know what to buy. Like, where do I even begin? There's a huge thing now among the industry, these big tech companies as well as the retailers, is that they realize you can't put these products on the shelf and everyone knows what to do with it. Mm-hmm. There needs to be a bit more guidance. So what I spend a lot of my time with now is actually something called the Consumer Technology Association. They are the main trigger that represents all the retailers and manufacturers. So we're thinking through what are the broad-based strategies for how consumers can be educated about what to do next, and that's what we're working on right now. And think about this is the same thing that's not uncommon, like years ago when it sounds crazy to say this, home digital blood pressure cuffs first came in the market. People didn't know what to do with it. Like, how do I do it, right? So there's a lot of broad-based information that dealers and manufacturers educate consumers. Same thing with sounds crazy, cell phones. I remember this, but years ago, cell phones you had to go through like a Verizon store, and you still do, but increasingly you could buy them. But there had to be some bit of assisted process still. So the whole hearing number campaign, that's I told you launching at the end of this year, where it's really going to be a broad-based national campaign. People start tracking their hearing themselves. That's step one. Is you have to have this general awareness of what your hearing is, and then from there, you know what your hearing is roughly. You know your hearing number is like a 10 or 15 or 20. You're like, oh, I could do something about it. You go to the Walmart, or the Best Buy, or you just go online, or even let's say even the bigger tech manufacturers like Samsung, Apple, whatever those, they start moving to market. they'll be informing you bit by bit about what to do. So that's just beginning now. But like I said, this OTC hearing aid market launched in the U.S. just a year and a half ago.
Yeah.
It's going to take 2 or 3 more years minimally to really settle out, because it's not often you see in the consumer market sector a completely new product category. You know what I'm saying? It sounds wild to say this, and you said yourself, right? Like, where do I begin, right? Because in the past, hearing aids was something you could only go through a doctor, like audiologist or ENT, to buy. You couldn't buy yourself. All of a sudden now, bam, overnight, you can buy over the counter. What do you do, right?
Yeah.
It's a process of how the market shifts to meeting that consumer need now. Is just beginning now.
Yeah, I wonder if it's going to be like with the optician now, where you just go every year.
Yeah.
Like people just regularly go for a checkup, if they're going to start doing that with their hearing and get their hearing number.
Yeah, I mean, just honestly, your phone, it's going to be a little app you download. You just do it yourself.
Yeah.
Right?
And is this something that is considered affordable for individuals who want to buy hearing aids?
So
what is the range we're looking at here?
So I think the range is, a good pair of wireless earbuds is what, $200? Okay. Should be the same price. The reason why I say that too, if you look at any good wireless earbud, whether it's Google Pixel Pros, Apple AirPods, or whatever, right? The components of a good wireless earbud that has a microphone, a speaker, a processor, things like that, they are no different than a hearing aid essentially. So we know that cost can be there, and eventually, as there's convergence, is that a Pixel earbud you're using, or a Bose earbud, or Apple AirPod, is that a hearing aid or or just a wireless headphone? It's the same thing. So yes, that is where the cost is headed.
That's great.
Because it's one and the same.
Yeah.
Okay, so we are reaching the end of the podcast. So it was very useful information that you covered today. I kind of want to leave with, what would be your take-home message for listeners who want to maintain cognitive health as they age?
So the goal of cognitive health, oh man, there are a lot of things, as we know this, right? So I would say first and foremost is remaining physically active, right? I mean, physically and socially active and engaged, right? So it's this general rule of thumb. One of my colleagues has this great tagline in his emails, and it's like, eat right, move more. What's the last one? Eat right, move
I've
more.
heard that before.
Right? And it's like that's like, in the end, it's so simple in the end, and really is true, but it's harder, easier said than done. But without a doubt, and obviously take care of cardiovascular disease things. Those are without a doubt, eating right, moving more, like one of the most important things. Beyond that, yes, I think hearing is another component of all of that too, especially think about addressing your hearing, think about your hearing not for the sake of quote-unquote cognitive health, but just because it helps you just engage better and hear your friends better in a restaurant and things like that. God bless, that's a reason to do it. And yes, maybe it has trickle-down effects on supporting cognitive health, but for me, it's almost, I shouldn't say this, it's really an afterthought at that point, right? There's clear proximal benefits, and we can lower the threshold for people being able to adopt hearing strategies technology by making people easily able to understand their hearing and then just activate the feature on their wireless earbud that allows them to work like a hearing aid. Then that's like, you lower that friction more and more, that becomes seamless with everyday life, and that's what makes it exciting.
So how can our audience stay up to date with your research and what we've discussed today?
I'll say there are a few websites I'll mention. So the Achieve study, all those results there are all on achievestudy.org, which is wonderful. And that constantly keeps track of where the trial's going and the results, things like that. The other big one for any listeners out there who actually just want to learn your hearing number, we haven't launched our Hopkins app yet, but already you can do it yourself. There are other apps that are free that you can do it only on an iPhone right now. The app will be launching later, so it will be Android and iOS. But right now you can already do it on an iPhone, and the website for that is hearingnumber.org. That's a site that is run by us at Hopkins, and that goes over what your hearing number is, how to get it, the apps you can download now, and then very soon, in a few months, you'll be able to download a dedicated Hopkins hearing number app, which will be completely free. We're not collecting any data. We're not monetizing it. It's just that consumers can easily get their hearing number, which you can now, but it's a little convoluted with some of these apps right now. The hearing number app that we'll release at Hopkins, which will be super simple, and just build in some next steps for what you can do too.
Okay. Well, we look forward to hearing about your future research, and thank you so much for talking with us today. It's been really interesting and really insightful, and I'm sure our listeners have learned a lot. So thank you for listening to the CVL podcast. You can follow us wherever you listen to your podcasts. If you'd like to learn more about the longevity and volunteer to participate in our research or donate to fuel innovative research to understand, protect and enhance the vitality of the mind across the lifespan, you can go to cvl.utdallas.edu.